So I will be presenting to you the pituitary apoplexy management according to clinical presentation. It's an experience in our department of endocrinology in Annaba. Donc c'est la gestion de l'apoplexie hypophysaire en fonction de la présentation clinique. Pituitary apoplexy, PA for short, is a rare, but not so rare, as it can reach 7% of pitnets, can be a life-threatening situation. Can be a life-threatening situation, so peut engager le pronostic vital. It is caused by hemorrhage or infarction of the pituitary gland, particularly within pituitary adenomas. Despite common mechanisms, its clinical presentations varies significantly among individuals. Conservative management emerged as a viable option, but no standard protocol can be applied to all patients since clinical presentation depend on severity of symptoms, which can be evaluated with the PAS or the PAGS score that we will develop later, and patient-specific factors, history, and comorbidities. PA can occur on a previously diseased gland by infarction or hemorrhage of a pituitary adenoma. Donc, elle peut survenir sur une glande déjà lésée par la présence d'un adénome hypophysaire, or a severe hypertension or shock on a healthy gland, which causes the well-known Sheehan's syndrome. Main symptoms is headache, alongside with vomiting and visual disturbances. Alteration of consciousness can also be seen, and hormone deficiencies are usually associated with gonadal deficit mainly. Some studies suggest that prolactin level can indicate the damage to the pituitary gland. So this is the pituitary apoplexy score that evaluates 4 items. We have consciousness, visual acuity, visual field, and ocular paresis. Donc, il évalue le niveau de conscience et les troubles visuels. Here we have a second score that is different from the first one, as it goes from the most severe symptoms to no symptoms. It combines visual acuity with consciousness. Grades are attributed accordingly, and decisions falls within a spectrum. It is influenced by modifiers, which are P, R, and S, so P for prolactinoma, R for rat case cyst, and S for severe comorbidities. When these modifiers are present, they reduce the decision a bit. So we present a prospective longitudinal study of 3 cases of pituitary apoplexy received in our endocrinology department in a lapse of 1 month from October to November, with a follow-up of 6 months. We collected medical history, clinical findings, paraclinical results, and follow-up data for these patients. PAS score was used in this study. All patients received initial primary care and by stabilization and monitoring of fluid and electrolyte levels, blood samples with hormonal, coagulation, blood count, liver, kidney function, and electrolyte assessment. All patients were diagnosed with MRI as the recommended test for this indication. Visual acuity, visual field, and ocular metricity were evaluated in the 48 hours and periodically. So clinically, we have 2 young females with pituitary adenoma. One had surgery for corticotroph adenoma. Second one was treated medically for prolactinoma. Risk factors were hypertension and aspirin and dopaminergic agonists. First patient had a pituitary apoplexy as the revealing event, alongside with alteration of consciousness and visual disturbances. Second patient has a yes. So both patients had combined hypopituitarism which was complete for the first patient. MRI practiced on all patients showed hemorrhagic lesions compatible with apoplexy. The two first patients had both NOP score of 4, but were attributed different PAS scores, 5 and 3. For the third patient, 1 was attributed for both scores. Second patient showed highly invasive characteristics in histology and a persistent Cushing. For the third patient, she presented intracranial hypertension with right papillary edema, which was revealed after practicing a lumbar puncture. Treatment: all deficits were substituted. First patient received corticosteroid boluses, dexamethasone, and dopaminergic agonists, and eye patch therapy. Considering his initial state and the lack of improvement, he was presented to surgery, but surgery delays allowed us to observe late improvement in his condition, so we maintained the conservative management. For second patient, surgery was ruled out because of highly invasive characteristics in histology, and radiotherapy and mitotan were preferred. For third patient, we temporarily stopped aspirin and DA, which allowed us to discover the intracranial hypertension, but then DA was reintroduced alongside with acetazolamide, which is Diamox. All patients showed full recovery except for endocrine deficits. So despite some same general mechanism, clinical presentation within these patients was totally different, and personalized management was necessary for each case in short, medium, and long-term follow-up. Recent meta-analysis studies suggest common protocols of management. Conservative treatment is initiated in all patients with PA by hormonal replacement in deficiencies, hemodynamic stabilization, specific treatment in case of evident underlying cause, and high doses of corticosteroids for their anti-inflammatory, anti-edematous effect, and corticotrope substitution. High doses of hydrocortisone were administered intravenously and then continued by continuous IV infusion or intramuscular boluses. Dexamethasone from 2 to 16 milligrams can be associated to reduce edema, and also we can add mannitol. So the balance between surgical and conservative management depend on clinical presentation and the severity of symptoms and their duration in time. But the limit of decision is not always easy to set, and therefore continuous evaluation and the employment of scores may help in the decision taken. Sometimes it is necessary to take time and assess our patient because late improvement can happen instead of proceeding directly to surgery. This study was conducted on 32 patients who only received conservative management. It showed radiological resolution and favorable neuro-ophthalmological outcome of pituitary apoplexy. These results imply that conservative treatment should be considered for tumor control and neuro-ophthalmic restoration, of course, if no deterioration. These meta-analyses also show that there is no statistically significant difference between conservative management and surgical management in matter of improvement of the endocrine deficits and visual disturbances. But it was under a selection bias since there are retrospective studies. So as a conclusion, I would like to share with you the algorithm used in our department where patients who are confirmed on imaging, we proceed with the general protocol that we described above, alongside with corticosteroids and dopaminergic agonists if suspicion of prolactinoma. Then we assess in diagnosis or from 6 to 48 hours visual acuity, visual field, ocular metricity, and Glasgow score for consciousness, which are items that are available in the PAS and the PAGS score that can help. High scores or severe symptoms, or worsening or even sudden effect would lead us to discuss early or late surgery. If practiced, donc si cette chirurgie est réalisée, we have to reassess our patients. If not, we continue conservative management and close surveillance. So conservative approach with symptomatic management and close follow-up may be considered in selected cases instead of immediate surgical intervention, of course, if no deterioration or risky situations. PA score system can help in making therapeutic decisions. The treatment of PA is multifaceted and dependent on many factors: symptoms, age, baseline comorbidities, and the expertise of the treating team. After initial treatment, close follow-up is required to assess complications or even recurrence of pit nets. Therefore, in each PA case, a comprehensive team approach is needed that will provide case-by-case management of the optimal method to treat PA. Thank you.